Hello, today we're going to be discussing testicular disorders and erectile dysfunction. You'll see there's several objectives we're going to be discussing in detail: testicular torsion, hypogonadism, hydrocele, varicocele, phimosis, and paraphimosis. We're also going to be discussing erectile dysfunction. The first thing is testicular torsion. Testicular torsion is a disease process that involves twisting of the spermatic cord, which can be a very painful condition. Things to consider is that this is considered a urologic emergency. There's a typical sudden onset of pain. There may be intermittent torsion where there's pain that comes and goes, and color flow Dopplers are studies that you can use to see this. Testicular torsion typically happens in a bimodal distribution. It happens in neonates, infants, and babies. It also happens, again, commonly in adolescent males. The left side is a little bit more common than the right, and it's usually preceded by trauma or physical exertion, but it can also be spontaneous. Signs and symptoms: sudden, severe pain, a swollen and tender testicle, nausea and vomiting, usually from the pain. The testes affected usually lies higher in the scrotum because the twisted cord pulls it up. There's also an absent cremasteric reflex, and there is no fever associated with this problem, which can help you differentiate it from some of the infectious causes of testicular pain. In this diagram, you can see a normal spermatic cord, and you can see a twisted spermatic cord. These are examples of what you might see in a clinical setting. On the left, a swollen testicle on that right-hand side sitting higher than the left. On the other diagram is a picture from surgery where you can see the testicle appears to be bruised or ischemic from the twisting of the cord. Treatments for testicular torsion are an immediate consult for urology. Get ready to have that patient go to the operating room. Do all your preoperative delays. You can do a Doppler ultrasound to prove the diagnosis if you want, but it may delay getting to surgery, which is not good. Detorsion, or manually attempting to turn that cord back, can be done. There's something called an open book method that involves manipulating the testis so that the anterior surface rotates from medial to lateral as if you're opening a book. From what I've read, in actuality, that's a very difficult maneuver, and it's rarely used. It's technically difficult as well as extremely painful. Once detorsion happens, the pain relief should be immediate, and do not delay operative intervention because testicular infarction or death of the testicle will happen within 6 to 12 hours after the event. Clinical pearls, things that kind of set it aside from other things. That cremasteric reflex is almost always absent. Patients may report similar, less severe episodes that spontaneously resolve. That's that intermittent torsion that we saw in the previous slide. Half of all torsions occur during sleep. That's an important piece of the puzzle. And abdominal or inguinal pain is sometimes present without pain in the scrotum itself. Hypogonadism. Okay, so there's this big axis that controls the development of testosterone and other hormones and androgens, essentially, in the testicle itself. And there's it's the hypothalamic axis, and so you have the hypothalamus producing GnRH, which affects the formation of testosterone in sperm. You also have the pituitary gland, and it's on a feedback loop, so everything is going forwards and backwards trying to make sure that we keep everything in homeostasis. The etiology of hypogonadism, or not enough testosterone, is insufficient testosterone secretion by the testes, decreased gonadotropin secretion by the pituitary, and you can also see this happen with people who drink a lot of alcohol or have Cushing's syndrome or chronic illnesses. The clinical features of hypogonadism include decreased libido, erectile dysfunction, fatigue, depression, and infertility. Signs that you might see on physical exam: diminished sexual hair growth, decreased testicular mass, not meaning a mass like a tumor, but size in general, and loss of muscle mass or muscle wasting in the entire skeleton. Diagnostic studies for hypogonadism include testosterone and FSH levels. Depending on what you see from those results, LH or prolactin, there are two different types of hypogonadism. That's why you need to check the LH and prolactin levels. And this is a nice little algorithm to kind of put it all together. But the number one reasons are where this arrow is. The reason that you check the LH is because you can have hypergonadotropic hypogonadism or hypogonadotropic hypogonadism, and primary gonadal failure is considered hypergonadotropic hypogonadism, and there are some specific disorders that go along with that. Klinefelter syndrome, cryptorchidism, you may see that with those patients. And then in the hypogonadotropic hypogonadism spectrum, you have GnRH deficiency, but you also have hyperprolactinemia and a cellular mass, which is a mass on the pituitary cell, a pituitary mass. The management of hypogonadism is number one, evaluation for prostate cancer and make sure there's nothing underlying that needs to be fixed. And then testosterone replacement, either orally, intramuscular, or transdermal. Androgel is the form of transdermal replacement, and then there's also just testosterone injections that you can give patients as well. Hydrocele. Hydrocele are a collection of fluid within the tunica vaginalis. Hydrocele are the most common cause of scrotal swelling. They are common in infancy and associated with testicular tumors 10% of the time. So the swelling is not in the actual testis itself, it's in the lining around that testicle, as you can see from this little diagram. And I have some pictures too. Clinically, it's painless swelling. The hydrocele will readily transilluminate. I have a picture of that to show you what that looks like. The patient may describe a feeling like a weight in the testes. Hydroceles can occur with epididymitis, which you're going to discuss in a lecture later in the week, trauma, hernias, and tumors. Or they can just happen on their own. This is an ultrasound picture of a scrotum, and let me see if I can show you. This is the scrotal sac out here. This is the testicle itself in here. And this is the hydrocele on either side. Okay. And this is an infant that has a very similar presentation to this ultrasound. And as you can see, by holding a light to the scrotum, you can see the light comes right through those fluid-filled hydroceles. It's a quick reference point in the office when you're trying to see what's going on. Remember, with hydroceles, there's no scrotal erythema, there's no pain, they transilluminate, it can happen at any age, there's no infertility associated, there's no dysuria, and there's no systemic symptoms of the problem. Varicoceles. This is another problem of the testicle. A varicocele is dilation of the veins within the spermatic cord, or the pampiniform plexus. Clinically, you'll find a soft, irregular, painless mass posterior and anterior to the testes. The swelling can collapse with the patient lying down, and it can refill with the patient standing upright. So that might be an important part of your physical exam, is to, the patient may be complaining about it. They may be laying on the table when you see it, and they may not see any actual problem. When they stand, they may come back. These are pictures of that swelling or dilation in those veins. Here's a diagram on the left, and on the right, sometimes you can actually see the problem like you can on that left testicle. The patient may say that it feels like there's a bag of worms in their scrotum or a weight in their testes. It's a little bit more common on the left, actually much more common on the left than the right, and it usually presents in patients who are over the age of 15. Remember, in differentiating hydrocele and varicocele and testicular torsion, that varicoceles do not cause erythema, they are usually painless, they do not transilluminate, they are not part of the testicle themselves. They're more common after puberty. There is no pain with urination. There are no systemic symptoms. Sorry for the typo. In older men, you have to also consider bladder and renal tumors, and these can cause infertility due to vascular abnormalities. Peyronie's disease, and I may be saying that wrong, it's been a long time, but this is a disorder that causes a dense fibrous plaque on the tunica albuginea of the penis itself. This is actually a penile disorder, which we're going to discuss more in the next lecture. It causes curvature of an erect penis. On a flaccid penis, you don't see any problems at all, but whenever the penis becomes erect, there's a problem. The etiology of that plaque is unknown. There's possible scar tissue resulting from microscopic tears of the tunica albuginea during intercourse. Actually, I must have had the picture in this one. Sorry, guys. So in the diagram, you can see where they're saying this fibrous plaque forms. This would be on the anterior surface of the penis itself, and then on the right is a picture of an erect penis with Peyronie's disease. All right, erectile dysfunction is a very, very common problem you're going to see in clinical practice. Essentials of diagnosis, direct from your book. Most causes of erectile dysfunction are organic, not psychogenic. Organic meaning it has a medical origin or not just something that's a mental issue. The incidence of erectile dysfunction increases with age, and there are a variety of treatments available, oral, injectable, and mechanical devices. Alright, I made this little table for you guys. Erectile dysfunction is not just dysfunction like you're thinking, where your patient says, oh, I just can't get an erection. You have to kind of distinguish what type of erectile dysfunction are we talking about. Are they saying they have no desire for sex? Because that's a loss of libido, and that is suspicious for an androgen deficiency. Okay, is it truly loss of erection? They are having the desire for sex, but they're not able to hold an erection, okay? And that can be associated with arterial, venous, neurogenic, or psychogenic causes. And within that grouping, you have inability to get an erection, inability to sustain an erection, which can also be helpful in deciding how to treat your patient. Okay, there's loss of seminal emission, or what's called anejaculation. Okay, that can be associated with androgen deficiency, sympathetic denervation from diabetes, or also from surgery. Retrograde ejaculation is something that the patient's not going to come in complaining of, but it's something to look at whenever you're trying to understand what's going on. It comes from a mechanical disruption of the bladder neck, especially following TURP or transurethral resections of the prostate. Okay, it can also happen with medications like alpha blockers, and it can happen with sympathetic denervation, either from disease processes like diabetes or from surgery. There's loss of orgasm, which is typically a psychological origin or psychogenic. Okay, and then there's premature ejaculation, which is usually anxiety related and rarely has an organic cause. General things to consider with erectile dysfunction: inability to maintain an erect penis with sufficient rigidity to allow sexual intercourse. That is the actual definition of erectile dysfunction. Okay, loss of erections, just like we said from the table, arterial, venous, neurogenic, or psychogenic causes. Many problems with erectile dysfunction are associated with concurrent medical problems, especially hypertension and diabetes, which is why we see it so frequently in treatment of patients. It can also happen with patients who have had radical pelvic or retroperitoneal surgery, and those patients are people who have had prostate cancer, testicular cancer, some of the abdominal and bladder cancers, fractured pelvises, lots of different trauma things that can come in there. Okay, you always want to look for concomitant cardiovascular disease. There's more and more data out there that says that erectile dysfunction can be a very early sign of cardiovascular disease, and patients should be worked up to make sure. Other considerations are, what medications is the patient taking? Because a lot of the antihypertensive medications can cause problems, okay? Beta blockers, thiazide diuretics are really common causes. So are some of the centrally acting sympatholytics, methyl-dopa, clonidine. Androgen deficiency causes loss of libido and erections, and lack of emission by decreasing prostatic and seminal vesicle secretions. If you don't have your androgens, you're not going to make sperm. You're not going to make the fluids that you need to have an emission. Psychogenic causes of erectile dysfunction are usually anxiety related. Sometimes that's due to a new partner. Sometimes it's due to having, your first partner. Sometimes it's just due to unreasonable expectations of performance. And then also emotional disorders. People who have had trauma in the past, or different things, they may not be able to have an orgasm, or they may not be able to even have an erection. So organic causes of erectile dysfunction, vascular causes, endocrine causes, neurologic, medications, alcoholism, and post-surgical change. Let me see what the next slide is. There we go. Okay. Vascular causes, cardiovascular disease, plaques forming in your arteries and veins, all the normal things that would cause you to have angina can also cause you to have erectile dysfunction. Neurologic causes, we talked about that before. Medications, we talked about that. Alcoholism, and post-surgical changes. Sorry for the repeat, guys. Alright, clinical findings, history. You definitely need to go to get history. Erectile dysfunction should be distinguished between ejaculation problems, libido problems, and orgasm problems. You also want to know the degree of dysfunction. Is it chronic? Does it happen all the time? Is it occasional, just now and then? Situational? Is it only with a new partner? Is it only whenever the patient's stressed? The timing of the dysfunction, that's difficulty in maintaining or difficulty in keeping. Difficulty maintaining or getting an erection. Determine whether the patient has any normal erections, especially early morning erections or during their sleep. If they're having normal erections, then an organic cause is less likely. It's more likely a psychogenic cause. Okay. Inquire about a history of heart disease, hyperlipidemia, hypertension, neurologic disease, diabetes, renal failure, okay, adrenal and thyroid disorders, and depression. It's also important to know if your patient's ever had trauma to the pelvis, pelvic surgery, or peripheral vascular disease. Peripheral vascular surgery. And then determine if they're using any kind of drugs, recreational especially, or, of course, prescribed medications, alcohol, tobacco. On a physical exam, look for secondary sexual characteristics, hair growth, general development, are the testicles descended? Is everything, are the testicles a normal size? Is the penis mature? Is it developed? Neurologic and motor and sensory examinations are important. Can the patient feel when you're touching in their perineal area? If they can't feel when you're touching in their perineal area, then they probably have a neurogenic cause. Peripheral vascular examination. Do they have a lot of varices in their lower extremities? Or do they have a lot of edema? Is there any evidence they have cardiovascular disease? Okay. You also, in males, want to examine their prostate. You have prostatic hypertrophy, but you can also have tumors that can cause some problems down there. Okay. And you want to look for penile scarring, and that's where you get into that Peyronie's disease. a lot of these patients will present, guys, and they're going to just, men are so different. They'll present and they're either going to be just cocky, literally, stating, "Oh, I want to be able to have an erection. I've got all these women, and all this kind of stuff," and they're going to complain about it, or they're going to be really embarrassed and they're not going to want to talk about it at all. And it's going to be really hard to elicit this information. So you have to be really patient and you have to really ask the questions. You would think that it's enough to say and they're just going to tell you all this stuff because they want help, but it's not usually like that. Most of the time you're really going to have to try and pull the information out of the patient because it's embarrassing enough for them to tell you that they have problems, much less to tell you exactly what the problem is. And it seems to me like they have more trouble telling girls than they do having guys, because it's a guy thing. So don't be afraid to really ask the questions, or to give the patients a questionnaire. There's nothing wrong with a questionnaire. They can kind of break the ice and get things going. The other thing to consider is a lot of guys with erectile dysfunction, they just want to fix the problem. They just think that Viagra is going to make them all better, and that's what they need to do. But honestly, there are some labs that you need to consider as well. Okay, a CBC, just their general health, see how they're doing. Okay, a urinalysis is important. You can do a urinalysis with micro. Urine specimens that have sperm in them have retrograde ejaculation, so it's important to think about that. Okay, a lipid profile. You need to make sure there's no underlying cardiovascular disease. Check their risk. Okay. Check a serum glucose, testosterone levels, LH and FSH, prolactin levels. Make sure there's not a pituitary disorder, okay? And you should definitely do those tests if you are worried about loss of libido or androgen deficiency, okay? And so that's what we talked about before, that they may help to localize the site of disease. Imaging studies, you don't really need imaging studies to diagnose erectile dysfunction unless you're worried about vascular causes. And then you can do sorry guys, I cannot say that word. Cavernosography, which is a contrast study of the penis that can determine site and extent of venous leaking. Okay, pudendal arteriography, cavernous arteries, duplex ultrasound. All those are looking just for vascular supply. Okay, there is also something called nocturnal penile tumescence testing. If a patient can't tell you if they're having erections in the night or if they're complaining they're not having erections in the morning, you can do it. I don't know anybody who does it, but you can do it. To help distinguish organic from psychogenic causes. Okay, there are multiple medications that can be used for erectile dysfunction. Hormone replacement is used for androgen deficiency. That's in the medications we talked about earlier. There are urethral suppository pellets that can be inserted literally right into the urethra. They're not as effective as a lot of the other agents, but it is something that's out there. Okay. PDE5 inhibitors can be taken 1 hour prior to anticipated sexual activity. These are the drugs we hear about on the news and the TV all the time. Viagra, Levitra, Cialis. They are contraindicated in patients who are receiving nitrates because they have properties that vasodilate, just like nitrates vasodilate. Okay. Patients who don't respond to one of the drugs may respond well to another. So if they tried one, and didn't have any results, they can try another. You should always try the lower doses first, see how they work before you go on. And there is a specific note here. All patients be evaluated for acute chest pain in the emergency department, urgent care, wherever you are. Should be asked if they're taking one of these drugs before you administer nitroglycerin, so you don't put them into congestive heart failure. There are injectable prostaglandins as well. And they actually say, honestly, that is a wonderful option for treatment. They also say that patients don't mind that you give it with a tuberculin syringe at the base of the penis, and that works, they say very, very well. Priapism is a condition with a prolonged erection, an erection lasting 4 or more hours with no sexual stimulation. Okay, that is considered an emergence condition, but it's also considered rare in patients taking injectables and PDE5 inhibitors, despite what we see on medical TV shows. Surgery is an option for patients who have erectile dysfunction, more for patients who have neurogenic or vascular causes. And there are out and out penile prosthetics. And there are multiple examples of these you can see in Access Surgery online, by the way, through Lapis Library. Okay, surgical disorders for the arterial system, vascular reconstruction, balloon dilation, and arterial bypass procedures for distal occlusions. Those are all vascular procedures. Okay. There's also a vacuum constriction device. The way this works is that you put this device on, and you has a vacuum seal, and the vacuum essentially pulls blood into the shaft of the penis so that you can actually get an erection, and you put a band around the base of the penis and remove the device to maintain that blood flow or hold the blood flow into the penis, and that maintains the erection, and you remove it afterwards. They say they're highly effective, but they are a little cumbersome, and that patients don't commonly like to use them. And then you also have to know that there's behaviorally oriented sex therapy for men with no organic dysfunction who are having the anxiety related problems. Alright, I made a scenario for you guys. Johnny is a 2-year-old who presents with his mom to your family practice. During a recent diaper change, Mom noted his right testicle is huge. She's really concerned. She's been online, and she thinks he has a tumor. He does not seem to be in pain. He has not been ill, and he's not had a fever. Do you have any other questions that you'd like to ask? If I was looking at this with you guys, I would say you should ask questions like, has he ever had any problems like this before? Does he seem to have pain whenever he goes to pee? And just systemic questions. The differential diagnosis is going to include several things. Testicular cancer, it has to be up there. It's an enlarged testicle. Okay. Hydrocele, varicocele, torsion. Okay, and then infectious causes that you guys have not gone over yet, so I'm not going to put you through that. Okay. And at this time, is there anything you can probably rule out? And generally speaking, I would say you could probably rule out testicular cancer, as this patient is only 2 years old, okay? And you could probably rule out testicular torsion because this is not a painful condition. You could also consider ruling out varicocele, but we need to keep investigating a little bit, okay? On his exam, he's afebrile. He's a normal height and weight. He looks like he's developing well. His heart rate and respiratory rate are normal. He's a very active 2-year-old. Your office may never be the same from all the activity that he has, okay? On his abdominal exam, he's non-distended. He does not have any pain in the suprapubic area, okay? On his genitourinary exam, you find a swollen right scrotum, non-tender, rubbery feeling mass. The skin is normal in color and texture. Both testicles are descended, and he does appear to have normal development for his age, okay? There's no edema in his extremities. What do you want to do next? It's an important piece of the puzzle, okay? At this point, at his age, with no pain, and no history of trauma to the scrotum, I'm really thinking that it's probably just a hydrocele, and so I think I would like to do some transillumination, okay? Holding a pen light to the scrotum reveals this. Alright, so that is transillumination, okay? And what do you tell Mom at this point, okay? You tell her that this is a hydrocele, that they're extremely common, that they're the most common cause of all testicular masses, that they're benign, that they get better, okay? They're not cancer, okay? And just in general, I want you to be thinking about, how do you differentiate between hydrocele and varicocele? Okay. How do you differentiate testicular torsion from hydrocele? Okay. Hydroceles and varicoceles differ in a mass in the testicle versus a thick mass or a bag of worms type feeling above the testicle and the spermatic cord. Okay. How do you differentiate testicular torsion from hydrocele? Pain, no pain. That's the number one way. Okay. When do you become suspicious for carcinoma? And that's going to lead us into our next lecture, which is on testicular cancer, prostate cancer, and other penile disorders. If you guys have questions, I'm going to do my best to create a discussion board on your Blackboard where you can ask questions.